السلام عليكم. هذا نور، خلينا نشوف الشات. وعليكم السلام. يس طيب، توكلنا على الله. هذه المحاضرة الثانية أقصر شوي من المحاضرة الأولى. To the point. I think it's easier because it's a valvular heart disease. يعني ما في complexity في الموضوع in terms of theoretical knowledge. So I want you to know the common valvular heart disease by the end of this lecture. Recognize the natural history of each disease and understand at least a glimpse on how you would manage these patients. نبدأهم with the most common valvular heart disease that can happen and the most common that you will see in your clinical practice. It's aortic stenosis. The majority of or the etiology is due to senile calcified AS that with like atherosclerosis that can happen in the coronary artery. Atherosclerosis is happening with calcification in the valves. With time and shearing stress, it deposits calcium, and with time, the orifice gets narrower and narrower until it produces symptoms. There is another factor that is responsible for giving aortic stenosis that can happen in up to 1 to 2% of the population. It happens earlier, i.e., the normal population at the age of 70. يعني 30-40% of them will have AS of varying degree from mild to moderate to severe. But the bicuspid aortic valve, which is a genetic malformation that is you're born with, the usual aortic valve anatomy is tricuspid 1, 2, 3. when you're born with the raphe, which is connecting two leaflets, making it a bicuspid, two-cuspid valve, you're at high risk of accelerating the process of this at a younger age. And it happens, usually they have their AS at the age of 40 and above. So they have premature aortic valve stenosis requiring treatment. In addition, they are associated, specifically the bicuspid aortic valve associated with aortopathy, coarctation of aorta. If you do an echo and you find an incidental finding of a bicuspid aortic valve, look at the descending aorta because up to 40%, I think, they do have coarctation of the aorta. The other causes of aortic stenosis, so the most common two causes, يعني لو جاكم في الاختبار, what's the most common cause of aortic stenosis? It's senile calcific AS. It's AS that happens due to aging. Bicuspid is the second, and then rheumatic heart disease. In our area, yes, it's endemic, but it's not common. It's not it's by far not the most common, but it can happen. With the rheumatic heart disease, usually affect the mitral valve, but it can affect any valves, including the rheumatic, causing inflammation, and then it causes the fusion of the commissions, causing AS. The rest are extremely rare, which is the congenital aortic stenosis, not bicuspid, it's just they are born with it, and this usually pediatric deal with it, and they are diagnosed early on in life. And rheumatoid aortic valve is extremely rare, where rheumatoid nodules formed in the valve and then cause stenosis. This picture is very important to understand. It's the hemodynamic measurement between the aorta in blue and the LV, which is in purple. The blue line المفروض يكون هنا. There should be no gap between the aorta and the LV. When the valve is open during systole, there should be no difference of pressure between. لكن patients اللي عندهم aortic stenosis that is significant, the valve doesn't open 100%, but there is a gradient. The pressure is high for the LV, while it is in the aorta very low because of the obstruction. And if you can see the shape of the gradient or the curve is a diamond shape, and that's exactly the sound of aortic stenosis murmur. And listen to the valve, how it, يعني أنا بديكم imitation of that valve. So this is a crescendo, decrescendo, diamond shaped aortic stenosis, murmur, ejection systolic murmur. مقارنة بالmitral regurg murmur, which is I hope انه في الزوم خلى الساوند افكت better. but you can see the difference. There is a crescendo في الأورتيك stenosis and decrescendo. Decrescendo معناها زيادة ونقص، فيزيد الصوت وينقص على شكل دايموند. بينما في الميترال ريجيرج or anysystolic murmur الثانية زي الفي اس ار or VSD it's continuous at one tone ويمشي زي كده. بينما ال AS is يزيد وينقص. It's very important in clinical examination. لما تسمع aortic stenosis, you're gonna find out this lesion. I'm sorry, I have to take this call, so just give me 1 second. Hello? I'm sorry about that. So that helps you to identify a shape of the murmur and differentiation on clinical examination. Symptoms usually it's the cardinal symptom of AS. كلكم راح تعرفوها ولازم تعرفوها لأنه ما يتغير كثير. Heart failure, dyspnea, angina, and syncope. These three are important. Why? Because the time of its initiation in the patient predict mortality. لأنه البيشنت اللي يجي بسينكوبي هم أقل ناس، بعدين أنجينا، وأسوأ ناس اللي هم الهارت فيلير. 235 من syncope, angina and heart failure the mortality is 50%. يعني إذا المريض جاته syncope المورتاليتي حقه بعد 5 سنين is 50%. الانجينا 3 years 50% will die without intervention. The last heart failure 2 years and they die. 50% of them will die. So 235 syncope, angina, heart failure are very famous. حتى في diagram ما أدري إذا موجود، لا ما هو موجود الدايجرام. في diagram that explain this curve of mortality. 50% of patient dies with severe symptomatic AS if they're not intervened. The physical examination will leave it into مثلا a bedside session, but something called pulsus parvus etardis, which is a slow rising, late peaking, low amplitude carotid. You put your hand on the pulse of your neck now, and you'll see it's stroking. يعني ما في تأخير. الضربة تيجي immediately at the same time of heart ejecting it. بينما because there's an obstruction, so it will happen slow and it happens late. لأنه أنت عادة البيك حق البلس يصير within seconds of systole. هذول اللي عندهم AS it will get delayed, and then this happens late in the presentation of systole, and that will cause a low volume because not the same amount of blood is going through the stenotic valve. The apex is heavy and sustained, so it gets displaced, low and lateral, and you can have palpable even some S4. There is a sign that is, if it's there, it's 100%. يعني في likelihood ratio حقتها بالinfinity يسموها. It's extremely high that if it's there, it's 100% the patient has aortic stenosis. What's this sign? It's called epicocarotid delay. ايش تسوي؟ You feel the apex beat and you feel the carotid beat at the same time. If there is a delay in between the beat that happens in your apex, the apex of the heart, and the carotid, there's AS because there's a delay. لأنه عادة ما في، المفروض يكون the same apex delay correlate with the pulse and the carotid. ما في أي delay. It's a one vessel and they are in direct communication with each other. المurmur description حقه زي ما ذكرت لكم crescendo decrescendo late peaking murmur. signs that you look for in your physical examination, S2, that is single, because with severe S2, severe stenosis, the A2 component will get fused with the P1, so it will lead for single, sometimes even soft S2 as a sign of severity of AS. Had a systole from purple to yellow. A murmur is increasing, late peaking, as you can see. Instead of its peaking initially, it peaks late, and then decrescendo into diastole. Investigation, most of them should and need echo, and echo is the way to diagnose them. Coronary angiogram is also done with where you put a pressure catheter for LV, pressure catheter for aorta, and you measure the difference, and then you give you numbers. You don't need to know the numbers, but anything above 20 is considered stenosis. It's a mechanical problem. هذا الدياجرام اللي قلت لكم عليه. See how from the onset of symptoms, what happened to survival. Within 2, هنا يقولوا 4, but لا هي 3, 2, 3, 5 is what happens to them. 50% of them would die. And this is very important because this you can change the outcome. يعني إذا شفت مريض عنده syncope with AS تقول له بعد 5 years 50% حتموت. If I replace the valve, your curve will change to normal. Whatever other disease you have, the curve will adjust up or down. Like for correcting the AS, you can change his mortality. That's why treating AS is very rewarding. It's a mechanical problem, and you have to treat it mechanically by replacing the valve. In the old days, it's only replacement with surgical intervention. They go and take the valve and implant a new one. Now we have a technique called TAVI, where we do implant percutaneously through an opening in the groin, a valve that is percutaneous, completely percutaneous, without the need for open heart surgery. Okay, so mechanical problem, mechanical solution, and that's it. When do you operate on them? When they have severe AS with symptoms, class 1 indication, severe AS with low EF, lower than 50%, severe AS with other cardiac surgery. هو رايح يسوي bypass, and there is a severe AS, خلاص, you have to replace it. ما حتفتح مرة ثانية, but you have to do the surgery at the same time. There are other softer indications, but don't concentrate yourself on it. Concentrate on the green. Symptoms, low EF, other cardiac surgery planned. This patient should go for surgery. There is a temporizing solution called percutaneous balloon valvuloplasty. It does work, but it's temporary, and it's not the best initial management because it will get restenosis. You are not solving the problem, you're just opening. And ينفع as a temporizing bridge to surgery, bridge to TAVI, but not as a sole treatment. It's a big balloon that you insert in the aorta and you inflate it. Okay, that's the TAVI. It's transcatheter aortic valve implantation. You don't need to know about the details about the different conventions and other. Then we're going to talk about different animal. If it's not a stenosis, it's a regurg. Aortic regurg, the causes of aortic regurg, and most commonly the chronic one, is degenerative from aging, because often if you have a severe AS, you are entitled to have a regurg that can develop into acute, chronic regurg. Endocarditis is the most common cause that can happen acutely. When the patient have a valve attacked by a bug, it can lead into degeneration of the competency of the valve, and that will lead into regurgitation during diastole. Leaflet prolapse due to aortopathy. إذا في aortopathy, the aorta get dilated with time. Eventually, when it dilates too big enough, coaptation will not happen. The closing of the valve will get incompetent, and then you have problems with the closure of the valve, i.e. regurgitation. Bicuspid aortic valve is also a common cause of regurgitation, as it is common cause of stenosis. Rheumatic, the same pathology. If it destructs the cusps, it will cause leakage. VSD, if you have a hemodynamically significant VSD, the jet and the vacuum effect that is created by the VSD sucks the cusps and causes regurgitation. These are the most common cause that you should know of. So degenerative, endocarditis, aortopathy, rheumatic, and a VSD indirectly causing regurgitation. What's the hemodynamic consequences of chronic aortic regurg? The pulse pressure gets wide. What's the pulse pressure? Is the difference between the systole and the diastole. Pulse pressure that is humongous, blood pressure 180/50, this is a huge pulse pressure. If it's more than 50, it's significant and it signifies, and the worse it gets, the worse the chronic regurg, the worse the pulse pressure gets. Okay, and it is associated with symptoms of heart failure mainly and dilatation of the rooms. Regurgitation is a volume overload status to the heart, and chronic conditions of regurgitation will lead into having dilated rooms, dilated left ventricle, dilated atria, and dilated right side too. What do you expect in examination? Pulse pressure that is high due to decreased diastolic blood pressure. Pulsus perspirans. What's pulsus perspirans? That it's changed with every stroke volume is different. One is strong, one is weak. The murmur itself, it's a decrescendo murmur, and it's during diastole. It is difficult to hear. So don't feel bad if you didn't hear it. Specifically, if the patient is acute, it's extremely difficult to hear a diastolic murmur. And if we have a bedside session, I can explain you the heart sounds and the maneuvers to hear these heart sounds. Decrease A2 because it's eaten valves, it's destructed valve. You don't hear A2 component of S2. S3 because the patient will be in heart failure. And you can have something called Austin-Flint murmur. Austin-Flint murmur, it's a diastolic rumble that is happening to the mitral valve because the regurgitation jet will push the mitral leaflet anteriorly and causes a functional stenosis in the mitral valve. There is no true mitral stenosis. Rather, there is a functional, because there is a regurg. The regurg pushes the valve and causes stenosis while there is no stenosis. The valve is normal, but the jet of blood affecting the mitral valve and causing stenosis. Okay? And that's how it looks like. Decrescendo murmur, ما هو زي الأورطة اللي هو crescendo decrescendo. Austin-Flint, it's a diastolic murmur هذا in the mitral area, not in the aortic. يعني ما هو, it's a diastolic murmur, بس ما هو related to the aortic valve itself. It is caused by the aortic valve, but seen in the mitral area. طبعا مشهور chronic aortic regurg being the disease of science, مليان science. Everybody هذه في ال 1800s عشان كان الsyphilis was common في Europe, and chronic syphilis causes aortic regurg. Every science يعني شافها واحد حط عليها اسمه and it became its science. Chronic regurg associated, هذه one of the common. There are more, plenty more. Musset sign, it's a systolic nodding of the head. The head is nodding with each beat of the heart. Muller signs, it's when you open the uvula, you see it's pulsating. Quinicke signs, you see pulsating in the capillary of the nails. Corrigan signs, the most important commonly asked in the exam is Quinicke and Corrigan, or the water hammer pulse. And this is a bit side, it's hard to explain without real examination. So each, there is a million sign, but what I want you to focus, or at least know, these three: Quinicke, Corrigan, and pistol shot, اللي هو Trope's sign. Okay? The same. For this, it's not as clear as aortic stenosis, but once the patient has symptoms, the degeneration of LV will happen. لأنه الخوف زي ما قلت لكم regurgitation, valvular heart disease في أي valve, it's a volume problem. Volume problem means that the chambers will get big. When the chambers get big, it fails and then the patient dies. So it is always catchy to catch it in the area when it's starting to dilate, so you prevent the cascade of going from LV dilatation, LV dysfunction and symptoms. Doing echo is your first. And then again, when is the indication? When there is a severe AR with symptoms low AF, other cardiac surgery plan is the indication. There is no medical treatment for this, of course, because it's a mechanical problem. You can help by reducing the afterload, i.e. increasing the antegrade flow. Acute aortic regurg, the same consequences. However, the cause is different. Endocarditis being the most common, aortic dissection, trauma, or prosthetic valve dysfunction. طبعا التروما احنا بما اننا country فيها الكار accident is a lot, it's a very common actually to see aortic valve dissection causing from any car accident. A sudden acceleration deceleration forces that happen to the aorta will lead to a shearing stress and displace the aortic valve, and it's actually fatal. Most of the time the patient dies on scenes. هذا ممكن سبب الوفاة اللي تصير اللي في حوادث السيارات الصدم اللي يكون فيها مفاجئ. I've seen cases where it was treated successfully, but if it was right on time. The other stuff, it's exactly the same as chronic. However, acute, the LV is not ready to receive that gush of blood, so the patient go into heart failure. Their lungs is white. They can't breathe and they need intubation. الكرونيك أخذ وقت. It's taking time for their heart adapted, volume adapt, then get large to accommodate that volume, and then it fails. But here they go into acute heart failure. Going quickly to mitral stenosis, it's also very not uncommon in Saudi عشان rheumatic heart disease. The most common cause is rheumatic. The other causes is just ignore it. If someone asks you what is the cause of mitral stenosis, go to rheumatic heart disease. نقطة. الباقي is just يعني cherry on tops, and you will never see it in your life unless you're specialized in mitral area. يعني أنا في السعودية ما شفت إلا aging causing mitral stenosis, calcification اللي هو آخر شيء هذا الآي، MS being the most common related to rheumatic fever as a child and the rheumatic heart disease. The problem is between the left atria and the left ventricle, so there will be a diastolic gradient because the flow of the mitral valve happens during diastole, so it's a diastolic murmur. And then the murmur itself initially will become later and later as the gradient increase. Symptoms, mainly it's palpitation, tiredness, and orthopnea and PND. These patients tend to have also atrial fibrillation. They're at higher risk of having thrombosis and then traveling into the brain. So each rheumatic MS with AFib need anticoagulation with Coumadin. They do have milder faces. If you saw a face that is pink, purplish, in these conditions, usually due to chronic hypoxemia. JVD is increased. Auscultation, it's funny. Initially, S1 will become loud because there's a calcification, and then it becomes soft and disappear even sometimes. Okay, so diastolic, it opening snap during diastole. When the valve open, it snaps, and then the flow happens with the rumbling sound. It might be too technical, يعني هذه bedside teaching, but it's very important to know it's a diastolic murmur. The most common cause is rheumatic heart disease. هذا أهم شيء. الباقي كله just for physical examination. وحتى في physical examination, it's beyond your level. And determining the mitral stenosis severity based on physical examination is not required at your level. And management, mitral stenosis, luckily, you can do it by balloon. With good result actually to surgery. We rely on a score called Wilkins score to see if the patient fits the need and the success of that procedure is done. So the patient go into cardiac cath where we go and insert a balloon and open the valve. One of the side effects of this, it can cause a mitral regurg. And when it happens, this patient definitely needs valve replacement. So it is something that you have to put in consideration. For this patient, if with significant mitral stenosis, balloon mitral valvuloplasty is an option. And surgery, if it failed, or even surgery from the beginning, if the patient has significant MR to start with, then he can't tolerate the balloon mitral valvuloplasty, then surgery is the only way for this patient. Mitral regurgitation, the most common cause, now خلصنا احنا mitral stenosis, now we're going into the most common seeing regurg, it's the mitral regurgitation. It happens due to a lot of causes. Rheumatic being one of them, mitral valve prolapse and myxomatous disease, and this is usually in young females. Infective endocarditis. After an MI, you rupture the papillary muscle, and that lead into acute MR rather than chronic. And functional MR, when the heart dilates due to heart failure, the patient is alcoholic and he gets dilated cardiomyopathy. The patient has idiopathic cardiomyopathy. It dilates. When the dimension of the heart changes, the mitral valve gets wider and there will be a gap in the middle. That will lead for a leaky valve that is tough. And this is a pathology. The reason is chronic or the mitral regurgitation is a different animal than aortic anatomy, because it's not a disease of the leaflet itself. حتى mitral valve, we don't call it a mitral valve, it's mitral valve apparatus. It's contained الcusps أو leaflet, الكوردة اللي هي زي الخيوط متصلة بالpapillary muscle, and it's the LV. Any change in function of these four parts can lead to a pathology. الAS ما في إلا الcusp, that's it. أو aortic valve. mitral valve is a complex valve. حتى التريتمنت حقنا for mitral intervention is not as good or as great as aortic. لأنه aortic is easy, mitral is difficult and complex. The only hemodynamic consequence you see for your level, it's a V sign or prominent V wave that happens during the ejection of blood. You see the neck vein gets higher on physical examination. Prominent V sign on JVP. This is also a bedside examination. The type of murmur, when you compare it to the aortic stenosis murmur, it's monotonic. شوف خط واحد ما في crescendo decrescendo. It's so it's continuous, and even if it was loud enough, it can mask the second heart sound. Indication for surgery, it's a bit tricky. However, when there is a low EF and symptoms, send for surgery, because they do better to prevent the damage of the left ventricle secondary to a valve. Mitral valve prolapse, it's a cause. I just want you to know that it's common in female with a predominance selection. It causes mitral valve regurg, and that's it. The rest is advanced information. This is a slide I want you to know, because often patients get prosthetic valve, and of them is the mechanical valves. Mechanical prosthesis, these patients should be on Coumadin, because taking off Coumadin, specifically at the mitral position, whereas the flow is not as quick as the aortic valve, the thrombosis can happen and can be lethal and can cause stroke. It can cause even occlusion of the valve orifice, leading to cardiogenic shock. So patient with mechanical valve should always be on anticoagulation, not aspirin, anticoagulation including warfarin. Okay? This is the indication of it, just as a summary. Mechanical valve needs anticoagulation, more riskier in the MVR position than in the aortic valve. I think that concludes the lecture. It was quick and painless. I hope that it's clear. I know the valve is a bit tricky, but it's a physical exam rather than theoretical. The most important point, and I mentioned it to you, to know the causes rather than the physical examination part of the treatment. Do you have any questions? If you don't have any questions, I wish you all a happy weekend. And hopefully I'll see you next week. We have the electrocardiogram and the arrhythmia lecture. إذا في عندكم أي سؤال سواء الآن أو in the future, you can reach me. Okay? يلا go enjoy your weekend. يعطيكم العافية. موفقين شباب.